not all the time the patient is coming with full-blown picture. For example, a case of cystic fibrosis, a child presenting with failure to thrive, malabsorption, chronic diarrhea, chronic recurrent respiratory tract infections, the mother telling you that I tasted the sweat of my child, it's salty. So all the pictures going with one disease. Maybe 1 to 2 differential diagnoses you put besides cystic fibrosis. But here it's, there is a wide range cause for it. So how you approach a patient with such complication or such presentation. So feeling tired, as we said, is a normal feeling. It's mainly either there is something going wrong with the physical energy, there's lack of energy, or there is a psychological or psychiatric problem with that patient. So these are the main 2 reasons. Sometimes it's combined. For example, you might have a patient with diabetes, a child with diabetes type 1, repeatedly receiving an insulin injection. He might feel tired all the time. The diabetes is one of the reasons for fatigability, but psychological problems also, anxiety, stress of that child is another reason for feeling tired all the time. Patient roja kalane champion injection work insulin lepanjesh dega roja shaja priki boga. Ama by itself it make a stress, make anxiety for the child. Sometimes you might refuse the treatment. So sometimes what I mean here is that physical energy, problems physical energy, with psychology may be combined. So what do I mean by physical energy? For our body to function, even during sleep, during thinking, you need energy. So physical energy means the ability of our cell or tissue to perform the metabolic reactions, for the chemical reaction or metabolism to be going on, or our body engage with this metabolism. We need energy. And how our body receive energy or deal with energy is through ATP. Okay, ATP is the molecule that carry energy. So for producing an energy, what we need, what the cells need, they need oxygen, of course, and they need a fuel from food. Okay, and the main source of fuel is usually glucose. So when there is problem with any one of these 2, oxygen or fuel, there will be lack of energy or impairment of the energy. As you see here, this is an example of the alveoli. This is alveolar wall, the orange cover. This one is the capillary. Okay. The smallest part of the airway is alveolar. This orange one is alveolar wall. This one is the capillary. So air is entering and going out. Okay. When the gas or the air reach the alveoli, it will be diffused. Okay, dissolved. It will be dissolved. And when the air coming, it's carrying what? It's oxygen. Okay, it will be diffused to the capillary. From the wall of alveolar wall, the blood or the oxygen will be diffused to the capillary. And what molecule holds the oxygen to our body? Hemoglobin will carry oxygen to the other tissue inside our body. So here the oxygen will be diffused to the capillary, so the blood here is contain high level of oxygen. Okay, when the blood coming again to the lung through the venous system, it's carrying CO2. So the CO2 again will be diffused from the capillary to the alveoli to be during exhalation, so the CO2 will go out. Okay, it's clear. This is a gas exchange. So any disease impaired, this gas exchange will affect, might result in hypoxia and decrease in level of oxygen. Another thing that's important is cellular respiration. And it appears that the cells, even the cells are breathing. They take oxygen, they need oxygen to make energy. Also, they need fuel, as we said. And the end result of the metabolism is what? It's ATP, it's energy, it's CO2, and it's water. So as if the cells are respirating. Okay, so for cellular metabolism, we need oxygen, we need fuel, as we said. This is cytoplasm, cytosol, this is mitochondria. As you know, the glucose here in the cytoplasm, glycolysis will occur, that the glucose will be converted to pyruvate kinase, and later on the pyruvate will enter the mitochondria, where pyruvate oxidation, Krebs cycle or citric acid cycle, and phosphorylation, oxidative phosphorylation through electron transport will occur all in the mitochondria. So the end result of each one of these chemical reaction is ATP. We need this ATP for cell structure, cell movements, excretion of waste products, metabolism of lipid, protein. For every function or chemical reaction, we need energy. So this is how the energy or the ATP will be produced. So the oxygen and fuel converted to ATP, which is an energy carrying molecule. So again, another reason is psychological motivation. As we said, this is a complex one, might be combined with the physical energy product, and it could be due to depression, it could be due to anxiety. And each one of these, when we say this patient is depressed, have special criteria for diagnosing a patient with depression. So there is a criteria, there is a duration for symptoms to say this patient having a depression or having anxiety. Sometimes maybe lack of sleep associated with psychological motivation. Regarding the pathophysiology, so as we said, if there is a problem with the energy production, metabolism, then we might have reduced ATP production. Okay, so reduced ATP production, this occurs usually when the cell receives too little oxygen. So what might cause a cell to receive little oxygen? What are the reasons behind hypoxia, let's say? There are several reasons. So poor oxygen supply, regarding the pathophysiology in general, for the lack of energy, and later on we discuss psychology. So poor lung function. So you have a disease might cause obstruction of the airway. When the airway is obstructed, so oxygen cannot go to the lung, and there will be no oxygen ventilation perfusion through the alveoli. So less oxygen will reach the tissues of the body. For example, we will give example for each one. Abnormal hemoglobin. Either there is problem with the hemoglobin itself, or the number of the hemoglobin is decreased. For example, in cases of anemia, or there is insufficient blood flow. For example, a patient with heart failure, the heart is not pumping blood enough, so less oxygen will reach to the tissue. So poor lung function could be due to COPD, it's obstructive lung disease. Could be due to respiratory muscle disease, myasthenia, any weakness in the muscle of respiration. When there is a weak muscle, this would also affect the quality of breathing. It might result in hypoxia. Oxygen transport defect, for example, in interstitial lung disease, lung fibrosis, the lung becomes stiff. So the oxygen cannot be diffused or transmitted between the alveoli to the capillary in a normal way. So there will be hypoxia. This is a picture showing a case with COPD. This is the normal alveoli, the above one, and this is the abnormal one. The abnormal one, you see that there is a secretion, there is a thickening of the bronchiole. This secretion and thickening result in obstruction or narrowing of the bronchioles, and finally it will result in destruction of the alveoli. So the end result will be hypoxia, less oxygen reaching to the capillary and then to the tissue. Another reason, insufficient hemoglobin. For example, we have many reasons for anemia. One of them, if there is substrate deficiency. There are certain substrates that participate in production of hemoglobin, like iron. So in a patient with iron deficiency, they will develop anemia, and when you have anemia, so as we said, the function of hemoglobin is carrying oxygen to the tissue, so there will be, those patients will be liable to hypoxia, and they feel tired all the time. They might have, even in severe cases, might have shortness of breath, exercise intolerance, non-functioning hemoglobin, as in CO poisoning. Low fuel, low glucose. Low glucose could be due to hypoglycemia. You have so many reasons for hypoglycemia, maybe due to fasting, or maybe due to a disease causing hypoglycemia, such as there are some diseases like tumors or malignancy affecting the pancreas might result in hypoglycemia. And low glucose transport across the cells is in case of diabetes due to insulin deficiency, which distribute the glucose to the cell. So when there is lack of insulin or there is resistance to the action of insulin, glucose transport through the cell will be affected. Low tissue perfusion, as we say in case of, for example, heart failure, the heart is not pumping, circulation is poor, so less oxygen reaches to the tissue. Abnormal chemical messengers, thyroid hormone are very important in the cell metabolism, even in the immunity, even in the cell growth. They participate in all of these metabolic reactions, especially in cellular metabolism. So when a patient having hyperthyroidism or hypothyroidism, they might feel tiredness or fatigability. Pathological mediators, cytokines are small proteins. They act as cell signals. So in diseases with connective tissue diseases, rheumatoid arthritis, SLE, due to these mediators, these cytokines, which affect the central, cause a central fatigue really, the mechanism is complex, and there are hypotheses about that. So these mediator cytokine might cause a central fatigability affecting corticotrophin, releasing hormones. And also these chronic disease, they always liable for stress, for anxiety. They have many medication, even side effect of the medication they are taking might produce fatigability. Sleep disturbance, insomnia, this sleep deprivation, or sleep apnea. Patients with sleep apnea, they have sleep fragmentation. They awake several times during. Oh, you can this big. Patients with sleep apnea, they have narrowing of the upper airway. So when there is narrowing of the upper airway, less oxygen will go to the lung. So these patients have intermittently they awake during the night. So during the day, you see a patient with sleep apnea, they are always look tired, sleepy. Okay. As you see, psychological disturbance, lack of motivation, decreased appetite, disturbance in sleep, early poor appetite. They don't like to engage in the normal activity, educational or social activities like the usual days. These are features of depression, but this is not enough. There is a special criteria to say this patient is having a depression. So now we come to the causes. Which organ, or let's say according to the map, which organ is involved in patient feeling tired all the time? Could be blood, hematology, could be a heart, could be a CNS. So any organ can be involved in the case of tired all the time. Regarding heart, as we said, heart failure. Regarding respiratory, give me example. Like a COPD we mentioned, restricted lung disease, fibrosis of the lung. Cases of, for example, chronic asthma, cases of asthma not controlled well, not on medication, not well for, they might feel also tired all the time. Anemia, any cases of anemia. We have, as you mentioned, we have thalassemia when there is abnormality. مايكا كيجناك أو إيه وشجر أو طاقتي نيت وأنا بشو تدرم غيابي شنا أو طاقتي نية بيوسي بمحاضرة كان يتكا بروا تدرم غيابي شنا. What other organ could be involved? Yes. Like, give me an example of endocrine causes. Why a patient with hypothyroidism or hyperthyroidism might develop fatigue? Can you give me? Yes, increase the basal metabolic rate. Okay. So what are the other features of hyperthyroidism? So loss of weight. Okay. What else? Hypertension, no, but you can see tachycardia. They can have a tachycardia. Okay. So weight loss, tachycardia. Sometimes there is a swelling of the goiter. Sometimes eye abnormality. Okay. menstrual cycle, disturbance of the menstrual cycle is very important features in any endocrine causes. Always in females, we ask about their menstrual cycle. Give me example of rheumatological disorder that might present with
anemia.
Even in rheumatological diseases, they are patient with medications or chronicity of the ailment. They might have anemia of chronic illness. Yes, but which diseases, rheumatological diseases might produce fatigability? Rheumatoid arthritis, for example, connective tissue diseases we mentioned, like SLE, and we have some other diseases like fibromyalgia. They always feel the pain in their muscles. What else? Yes, multiple sclerosis. Yes, those patients have neurological deficit. They are taking a chronic medication. They are liable. Which medication might produce fatigability? These are anticonvulsants. Yes. What else? Several organs involved. After you exclude these causes, and by history, physical examination, now we come into history and physical examination, sometimes investigation. If you didn't find a cause for TAB all the time, sometimes maybe you have a syndrome called chronic fatigability syndrome. In this syndrome, its usually duration is 6 months and more. The patient feels tired all the time. You do investigation, history, physical exam, you don't find the cause. And sometimes they have headache, joint involvement, mentality involvement. So you might think this patient is having a chronic fatigue syndrome. This syndrome has special criteria for diagnosis. Even if you have a patient that his presentation doesn't go with the criteria for chronic fatigue syndrome, you might think this patient is having idiopathic fatigability. But this is diagnosed, we always say this is a diagnosis of exclusion. We don't say this is idiopathic until we do a thorough follow-up for the patient. Finally, if we didn't find the cause, we can see this idiopathic one. History. So, in any presentation like the previous one, sickle cell, cystic fibrosis, myocardial infarction, the basic is very important. If you understand the basic, okay, then you integrate the basic science with the clinical one, you can reach the diagnosis. يعني مو دكتور يشك بيسك كي باشا يشك يجلا بيسك نازانه فقيه هم ما نتوين treatment patient but you know the prognosis, you know how you approach the case from initially, if you know the pathophysiology of the patient, this will be helpful not only for you, even for the patient. يعني جربته كبيسكي نخوشك نزاني هل خطو تريتمنتي همش تبعنا درك هي زوج حالك يعني سيرك يدو انتباهاتي كيمونوسيون ستيرويديات يعني هالحالة بيرجع قبته مزامي ديك لاكواني جتفاني do the CDA but they don't know anything about the pathophysiology or basic of the disease. That's what differentiates the doctor from the paramedics. One point in approaching a case is history. History is very important. Most of the time, by history, we reach a diagnosis. 85-90% of cases, the patient will. This doesn't mean that exactly the patient will tell you the diagnosis. It means listen to the patient. يعني هني جا patient كي الله سرمش تقول له خذي والله يا ولد أنا شو ناخذ بيان فلان درمان خوارد ولا مش خذها جاش تبدأني يترجون نخوش كنا عمي خير باراسtamol بس أنا هذيك could be a meningitis, CNS infection, could be a tonsillitis, could be an otitis media, Could be an influenza, could be COVID. So don't put diagnosis in your mind from the beginning. يعني أو diagnosis اللي مش كده عشان تقول أنا مش كان أبي بهيش شيء الله بس يشيلها. عشان زوجة إما مثلا investigation أنا نردوها تشخيص يقدر شو دواي جماعي لتوستري مع برسيو أفلام شيء أو أرسي لكن تفرق معنا ولا يستيقظ قبل بداية ولا يستيقظ كمان شو عمر بتاع بيجيبوا هم investigation أنا أعرف. So always listen to your patient. Don't interrupt the patient. Okay. So what are the important points in the history? How the condition started suddenly. Is it associated with any live event? يعني اشتغلوا أو fatigability إلى آخره. Any illness نخوشي له إلى آخره نخوشي له. So how the condition started suddenly or gradually? Duration of the illness, for how long this patient feeling the fatigue, because later on you take fatigability in detail because you have acute, subacute, chronic fatigability. Daily pattern, which time of the day the patient which time of the day the patient feel tired. How this condition, always it's very important to know how the condition affect life of the patient, affect the intake of the patient, the food intake of the patient, the daily activity of the patient, engagement in social activity and educational activities. Associated symptoms, for example, you have a patient with fatigue and having a fever. So this will make me to think about infection, for example. A patient having tiredness all the time and having weight loss. I might think of sudden weight loss, might think of tumor or malignancy or sometimes thyroid problem like hyperthyroidism. Okay, a patient having snoring at night and feeling sleepy all the day. This might be sleep apnea. Patient having pallor, okay. So this is called history of present illness, how the condition started, and we call it, when we take a history تاخر ولا نيجي بتاع باسكرا.
La concept.
The communication skills usually in history, especially in the beginning, we take the detailed name, age, date of birth of the patient, residence of the patient, what's the complaint of that patient, history of present illness, mean for how long the condition being there, what is the chronology of the symptom, how the condition started, how it's progressed rapidly or slowly progressed disease, any associated symptoms, how this symptom affect the daily activity of that patient. Later on, we review each system, heart, neurology, musculoskeletal, genitourinary, we review all the systems. Then we come to past medical history. Does this patient have any disease? He might tell you, I'm taking this medication, I have diabetes, I have hypertension. Family history, is there any family history of connective tissue diseases, of heart diseases, okay, or thyroid problem? Nutritional history, again, is very important. For example, you have a patient feeling tired all the time, anemic, and he or she is telling you that I'm vegetarian, and he's not taking any supplements, so they are liable for what? For B12 deficiency, for example. They might develop anemia as a result of that. So just by history, I might diagnose that this is most probably a case of B12. Then later on by investigation, I'll prove my diagnosis. Psychosocial history, again, is very important. Any drug abuse, any substance abuse, alcohol intake, physical examination. So what you see in general in that patient. Patient having a pallor, having a yellow discoloration of the skin, having cyanosis, having distressed look, having a shortness of breath. You have seen the patient previously and now you see the patient again, he lost some weight. These are, in general, observation is very important. You check vital sign of the patient, pulse rate, respiratory rate, heart rate. A patient with hyperthyroidism, as we said, they have tachycardia, okay. While hypothyroidism might have slowing of the heart rate. Patient with anemia have pilot. Patient with liver problem, for example, hepatitis infection, hepatitis due to infection, drugs, or anything, they can have present with jaundice. Fever, we think of infection. Lymphadenopathy, you have a patient with fatigability, weight loss, lymphadenopathy, and you examine their abdomen, their spleen or liver enlarged, and you will think of malignancy, leukemia, malignancy of the blood. Then we come to systemic examination, abdominal examination, respiratory, all of these will help. How we approach in real life as a doctor, how we approach a patient with any presentation that's vague, not clear. We take a proper history, we do a proper physical examination until we reach a diagnosis. And believe me, sometimes the patient coming for a disease and during your examination you might find something else. For example, in the past few years I had a patient, 10 years old girl, presenting with dysuria and frequency. So it was obvious that this patient have urinary tract infection, this girl. Simple urinary tract infection. I could just write a general urine examination and antibiotic and go home. I did an abdominal examination. During my examination, I found the spleen very enlarged. Very enlarged. And the case was totally asymptomatic, no problem before, in a good general health. And finally, we diagnosed her as a case of autoimmune hepatitis. And now it's the case on immunosuppressant drug. If it wasn't diagnosed early, those patients, sometimes they present with liver failure. And the body is very fail, this year, the hepatomegaly. So what I mean here that taking the patient as a whole, يعني كهستري لو رأيت إنها ولا سرمنشة تو بس بيجي رأي ممكن نفسر إشي لو أنا respiratory cause لو أنا CNS cause لو أنا upper respiratory or lower respiratory cause هذا. Or could be a psychological, a drug causing that presentation. Could be a trauma, could be a tumor. Okay. So we try from first stage to teach you how to think broadly. Okay. And take the patient as a whole. When you receive a case and there is, you have a time, examine the patient as a whole. Finally, after taking a history physical examination, you come to the lab investigations. Accordingly, for example, I'm suspecting that this patient have pilot, might be anemic. I send for blood investigation called CBC, looking at the HB, red blood cell, white blood cell platelet of that patient. If I suspect iron deficiency, there is a special test called iron profile. I'm sending for ferritin iron level to diagnose it. A patient having electrolyte imbalance problem with the, for example, hypocalcemia or hypokalemia, I have to send for electrolyte to diagnose the situation. Patient with thyroid problem, as we said, I have to send for thyroid hormone test, TSH, T4, TSH. Patient with diabetes, I have to send for fasting blood sugar and sometimes HbA1c for diagnosis. Besides the history, I have to send for investigation. Patient with jaundice, I'm suspecting hepatitis, I'm sending for viral hepatitis. Multiple complaint, and the patient having, for example, sudden weight loss, multiple infections, lymphadenopathy, I might think of HIV infection. And other investigation accordingly. يعني من case recommend systemic lupus erythematosus (SLE). There is a special investigation to be sent for that disease. Rheumatoid arthritis special investigation. أما whatever which مطلوب يعني how we approach cases. And we come to the management accordingly. Management accordingly. Diabetes, you should treat diabetes. Hypertension, you should treat it. Medication causing fatigability, you should stop that medication. Okay. A patient having a psychological problem, you need to do a psychiatrist consultation. Okay. If you didn't find the cause of the patient having idiopathic one, you even might try cognitive behavioral therapy with psychotherapists or psychiatrists, exercise therapy, and sometimes trial of we see that antidepressant by itself might cause a fatigability, but sometimes in idiopathic cases can be used as a trial of treatment for idiopathic one. So that is a very challenging subject. It has multiple causes. with different physiology and pathophysiology. I hope during this small group session, you start to make a concept map. Think again which organ is involved, what is the pathophysiology behind the feeling tired, which is lack of energy or psychological problem, and then how you take a history physical examination, how each disease that we mentioned might present, which point in the history is important. Well, you know your task is to identify the map in a logical way and understanding diagnosis and management of a patient who is feeling tired all the